Welcome to Beyond the Chart, a healthcare podcast about all things medicine. We explore lessons behind the most challenging cases and discuss current issues affecting our system. Today, we're discussing a sobering patient safety case from the HRQ Patient Safety Network titled "A Cognitive and Communication Blind Spot Contributes to Permanent Paralysis." This case demonstrates how breakdowns in communication, cognitive bias, and limitations of the electronic health record can combine to delay recognition of neurological emergency. Although no single mistake causes patients devastating outcome, a series of missed opportunities ultimately resulted in permanent paralysis. Our patient was a 38-year-old man who spoke very little English and was involved in a high-speed motorcycle crash. He arrived at a trauma center with severe injuries, altered mental status, and respiratory distress. His Glasgow Coma Scale score was 6, indicating severe impairment of consciousness. Attempts to place an endotracheal tube were unsuccessful, requiring an emergency cricothyroidotomy to establish an airway. Initial imaging revealed numerous traumatic injuries. He had a small traumatic subarachnoid hemorrhage, a fracture of the occipital condyle, a traumatic C6-C7 disc rupture, multiple bilateral rib fractures with hemothoracis, and a right-sided hemopneumothorax, pulmonary contusions, a thoracic spine fracture, and a fracture of the left proximal humerus. Because of his severe injuries and aspiration pneumonia, he remained mechanically ventilated in the intensive care unit. On the second hospital day, the trauma surgery team ordered an MRI of the brain because they were concerned about possible hypoxic brain injury following his difficult airway. At the same time, the spine service requested an MRI of the cervical spine to determine whether surgical stabilization would be necessary. The MRI studies were completed on hospital day 6. Fortunately, there was no evidence of hypoxic brain injury and no significant ligamentous injury requiring stabilization. However, the radiologist documented a subtle but important finding. A small cervical epidural collection of blood or fluid extending behind the spinal cord. At that time, there was no evidence of spinal cord compression. Unfortunately, this incidental finding was not documented in the progress notes by either the trauma surgery team or the spine consultants. Meanwhile, because the patient had multiple fractures, prolonged immobility, and a high risk of venous thromboembolism, he had already been started on prophylactic unfractionated heparin on hospital day 4. Over the next several days, the patient's neurological status slowly improved. He became more awake and was intermittently able to follow commands in his native language. However, he remained ventilator dependent and was still critically ill. Then, the first warning signs appeared. On hospital day 7, the bedside nurse documented withdrawal of both lower extremities to painful stimulation. The following day, the nurse noted that there was no response from either leg. On hospital day 9, nursing documentation clearly stated, unable to move both lower extremities. Sensation intact, team aware. Despite these concerning findings, the physician progress notes continue to describe the neurological examination as moves all extremities. For several more days, the discrepancy between the nursing documentation and the physician documentation persisted. Finally, on hospital day 13, the patient's inability to move his legs was fully recognized by the treating team. An urgent, repeat MRI was obtained. The MRI demonstrated a large cervical epidural hematoma extending from C3 through C7 with significant spinal cord compression. The patient underwent emergency cervical laminectomy and decompression. Unfortunately, the diagnosis came too late. Although surgery relieved the compression, the patient was left with nearly complete paralysis below the C7 level. At 6-month follow-up, he remained permanently paraplegic. So what went wrong? Like many patient safety cases, this was not the result of one catastrophic error. Instead, multiple communication failures and cognitive biases aligned to delay recognition of a time-sensitive neurological emergency. The first major issue involved communication between members of the healthcare team. The nursing staff appropriately documented worsening neurological findings over several days. They even documented that the team had been notified. However, the significance of these findings never reached the entire care team with the urgency they required. A sudden loss of motor function should always be treated as a neurological emergency until proven otherwise. Whether the cause is stroke, spinal cord compression, expanding hematoma, or another acute neurological process, delays in diagnosis can lead to permanent disability. The second communication failure occurred between specialties. The radiologist identified a small cervical epidural hematoma on the initial MRI. Although it was not compressing the spinal cord at that time, it represented an important finding in the patient receiving anticoagulation. Neither the trauma service nor the spine consultants documented this finding or appeared to incorporate it into ongoing clinical decision-making. Had the team appreciated that an epidural hematoma already existed, they may have monitored the patient's neurological examination much more closely and reconsidered the risks and benefits of continued anticoagulation. Another important lesson involves cognitive bias. The MRI had primarily been ordered to evaluate ligamentous injury and possible hypoxic brain injury. Once those questions were answered, clinicians may have unconsciously stopped searching for additional abnormalities. This represents a form of anchoring bias. When clinicians focus on answering one clinical question, unexpected findings that fall outside of their original diagnostic framework may receive far less attention than they deserve. The electronic health record also contributed to the delay. For several consecutive days, physician notes documented that the patient moved all extremities, despite nursing documentation showing progressive paralysis. This highlights one of the growing challenges associated with modern electronic medical records. Copying and pasting previous examinations, relying on auto-populated templates, or failing to independently verify physical examination findings can unintentionally propagate inaccurate information throughout the medical record. Once incorrect documentation appears repeated, it may falsely reassure other clinicians reviewing the chart. The patient's clinical condition also made recognition more difficult. He was critically ill, mechanically ventilated, obese, recovering from severe trauma, intermittently awake, and communicated in another language. Detecting subtle neurological deterioration required careful, repeated examinations and effective communication among nurses, physicians, consultants, and interpreters. However, these challenges make thorough neurological assessment even more important, not less. Another important discussion raised by this case involves anticoagulation after traumatic injury. This patient clearly had significant risk factors for venous thromboembolism, including prolonged immobility and multiple orthopedic injuries. Starting prophylactic heparin was therefore a reasonable decision based on available evidence. At the same time, anticoagulation carries a known risk of bleeding. Once a small spinal epidural hematoma has been identified, clinicians were forced to balance the competing risk of thrombosis and hematoma expansion. There is no perfect answer in situations like this. Instead, recognizing the existing hematoma should have prompted heightened vigilance for any neurological changes. This case reminds us that treatment decisions often involve balancing competing risks rather than choosing between right and wrong. So what can we learn from this case? First, communication must be active rather than passive. Simply documenting that the team is aware is not enough when neurological deficits develop. Critical findings require direct communication. closed-loop confirmation, and timely escalation. Second, nurses, physicians, consultants, and radiologists all contribute unique pieces of the patient's clinical picture. Patient safety depends on integrating those observations rather than viewing them in isolation. Third, clinicians should remain aware of cognitive biases such as anchoring and unintentional blindness. Unexpected findings deserve careful consideration, even when they fall outside the original reason a diagnostic test was ordered. Fourth, electronic health records are valuable tools, but they should never replace independent clinical assessment. Every physical examination should reflect what the clinician actually observed rather than what was documented previously. Finally, any new neurological deficit in a hospitalized patient should trigger immediate evaluation. Time is spinal cord tissue, just as time is brain tissue during a stroke. Delays of even hours can determine whether neurological injury becomes permanent or not. In closing, this case reminds us that excellent patient care depends not only on the medical knowledge, but also on communication, teamwork, and careful attention to changing clinical findings. The spinal epidural hematoma was visible before paralysis occurred. The neurological changes were documented before irreversible injury developed, and multiple opportunities existed to intervene sooner. Recognizing just one of those warning signs may have changed this patient's life forever. Thank you for listening to today's morbidity and mortality episode on Beyond the Chart, a healthcare podcast. Until next time.